Roundings in the Psychiatric Environments by Deborah Olania. My topic talks about the significance of rounding, especially in psychiatric environments, which is basically to eliminate or reduce fall risks and prevent suicide risk behavior in persons identified to be suicidal. This is important in nursing because our psychiatric patients, specifically our geriatric psych patients, are at greatest risk for fall due to age, 65 or older, cognitive decline, whether they have dementia or Alzheimer's, medications, whether they are doing a polypharmacy or taking multiple meds, or they're having med adjustments based on behavior, and also isolation. Basically, if they are left alone for an extended amount of time, they can have an increased risk of high risk behavior, such as fall. Some of our high-risk behaviors also include suicide, those that are identified at admission and throughout their extended stay and even up until discharge. My PICOT question is basically in nursing, how can shorter interval rounding compared to longer interval rounding affect falls or suicide risks within your 12-hour nursing shift? We are just compartmentally showing each shift because we need to focus a shift at a time versus the whole entire day so that we are meeting the needs of our patients kind of in a time reference. In my research that I found, an article titled A Model for Rounding with Patients in a Psychiatric Hospital kind of talked about the 1-hour rounding where mental health basically is not taken seriously perhaps as other medical environments, and this may be due to the unstable behaviors exhibited by this population. So what they talk about is the I-CARE, which is a theoretical model for rounding within that hour. So the I-CARE breaks down to I, which is introduction. You're introducing yourself to your patient. The 6 C's of compassion at that time, which encompass compassion. So basically you are engaging and interacting with your patient in a compassionate manner. You're displaying competence. Basically applying some of those suitable level of knowledge and skill to that interaction. You are confident. So basically when you have the knowledge and you have trust and loyalty in what you are doing, you display confidence. Some of that consciousness we talk about is being mindful of any moral or ethical issues that may come into play that make you uncomfortable, make the patient uncomfortable. We are talking about commitment, basically your allegiance to the necessities of that patient. And comportment talks about the attitude and the physical being of you overall in that area. You're also going to assess the environment, seeing what is the need of the patient at that time to help reduce stress. We're going to reassure that patient that you are available for them if they need anything. And also we're going to reassess the environment to make sure we don't have anything that would increase fall or ligature risks for suicide patients. Our research basically talks about the impact of rounding in a geriatric psych unit. In this particular article, they discuss a 2-hour rounding schedule as their safety tool rather than a typical 1-hour rounding measurement tool, because this 2-hour rounding emphasizes intrusiveness in our dementia patients. Typically they are more stimulated, so we want to reduce stimulation by reducing the amount of time that we are being intrusive. We're also going to emphasize the 5 P's, where we are addressing pain, personal needs, position changes in the bed to help reduce those pressure ulcers, possessions if they want to be tucked in a little bit more or more blankets, and then PO intake to address hydration to reduce UTIs. And then also in this time frame, in a 3-month time frame, this tool was instrumental in a 70% decrease in the falls. When we talk about our suicide patients, we talk about the ligature risk requirements. We talk about identifying our suicidal patients because suicide is identified as the 10th leading cause of death in the United States, taking more than 40,000 lives in a single year. So deaths usually are ranged from bedrooms to assistive devices or hanging in the bathrooms, door handles, hinges, light fixtures, or ceilings. So we emphasize that one-on-one patient observation to help kind of eliminate that ligature risk in our suicidal patients. Another article that I found is titled Implementation of a Structured Rounding Tool for Interprofessional Care Team Rounding. This emphasizes daily or weekly rounding of the interdisciplinary team to contribute to this patient-centered care. When teams fail to communicate, it's found that 32% increase in patient incidents happen. So the inclusion of other disciplinary teams in patient rounding, such as dietary or psychiatric or medical doctor or nursing or just ground level personnel, it helped reduce incidences in adverse errors, mortality, and morbidity rates, thus improving positive patient outcomes as well as proper discharge planning from admission, because typically these psychiatric environments are temporary, so we are wanting to secure their safety from admission and on to discharge. I plan on disseminating this by having weekly meetings with the director of nursing, charge nurse, and psychiatry. Every Tuesday is when we typically have these individual plan meetings for each person so we can determine what their needs are. We will also have weekly 1-hour meeting prior to each shift to address changes of the care for the direct care staff to determine each individual need of each patient. We can then determine if a 15-minute rounding tool is necessary for our high-risk patients, if there is a need for a one-on-one for suicidal behaviors, if that 1-hour rounding tool is helpful when they're sleeping, and then also a monthly fall report for trends and best tools that were utilized. Thank you.